Welcome, everyone, to Hystericology Podcast. You're here with me, Dr. Elizabeth Beckmann, and
Andrea Hanson.
We are so excited today to have a guest that we are going to be able to explore something that Andrea and I have talked about throughout some of our past podcasts, but maybe we can go into a little more depth with our guest, Dr. Damian Wilde. He is joining us from Liverpool, England. And Damian, if you can tell our listeners a little bit more about yourself before we launch into our conversation.
Yeah, absolutely. Well, thank you for inviting me on, Andrea and Elizabeth. It's great to be here. We've had some interaction and conversations on LinkedIn. I think that's sparked a mutual interest within the area of psychological health. So I'm a clinical psychologist. I originally worked as a primary school teacher. It's maybe what you call over there kindergarten.
Yes.
So bit of crisscross with sort of language at different points, but so I was a teacher, and that was a profession that I enjoyed, took a lot out of, but I had a really interest in clinical psychology. So I've gone off, worked in various junior positions, completed my doctorate in clinical psychology at Coventry and Warwick universities in the Midlands area of England. I've then gravitated back to where I grew up, which is near Liverpool in England. I've done a lot of work in England, what we call CAMS services, which are child and adolescent mental health service. So usually working with children and young people aged between 5 and 18. And I've also worked in adult services, 16 plus age range. In one service, I set up a psychotherapy part of the service. Now, during my training and during my sort of postdoctoral post, amongst other duties, my main specialism is psychodynamic psychotherapy. So I'm a big advocate of providing people with a safe, containing, protective space to explore themselves, to explore their experiences, all within a warm relationship. So I mainly worked for the National Health Service in England, but just recently, I've set up my own private practice. So I've called it Wilde Psychology. So it's got the name in there. And so I'm providing therapeutic work in schools, psychotherapy with adults, supervision, training. So that's another way of being able to kind of disseminate to sort of a larger kind of range of people. So yeah, sort of the new venture is finding its feet, and I'm building that up. And I'm just happy to be here to talk about some topical and important things within field of mental health, things which I think need raising awareness about.
Yes, and we are so excited to have you here. I've loved your posts. I've loved our interactions on LinkedIn. And so for the listeners today, we are going to be focusing on informed consent. What is lacking currently in the informed consent when it comes to mental health services? And of course, we are all clinical mental health counselors in some way. We are not psychiatrists. However, we're also going to be talking about what's lacking there. As mental health therapists, our work overlaps a lot with psychiatrists, and we work hand in hand with psychiatrists at many different types of clinics. So we have a really good understanding of what happens there, as well as, keeping up with the research. So with informed consent, what that means is when you go to a doctor, when you go to a therapist, you should have some paperwork that you do at the beginning, and you should have a discussion similar to if you go into a surgery and they give you a huge stack of paperwork and it tells you all of the bad things that could potentially happen as a result of the process and what to expect from the process. So from my experience in training in doing informed consent, in offering informed consent with clients, it's usually pretty short. As a therapist, we go over, confidentiality, the limits of confidentiality, what to expect from the treatment process. There's no magical cure or anything like that. And that is really the extent of the baseline of the process. What about for you two, Elizabeth and Damian?
I know for me, everything you said, Andrea, is what is included in the informed consent process that I go through with my clients. I also having my private practice not working with insurance, I always try to provide a little bit of extra information too about what it means to receive a diagnosis, because working private practice, I don't have to have a diagnosis in order to justify insurance compensating me. I've agreed upon a particular fee, a particular rate with a client. And so often, sometimes I'm even letting them know how I operate and that how that's going to look a little bit different than another clinic. And where often I don't necessarily fixate on the idea of having to give someone a diagnosis. And I talk about some of the limitations of diagnoses and what that can mean to a person moving forward, which is not something I know that I engaged in when I worked at clinics, because that was a part of the protocol. Is you're going to meet with them, and within the first or second meeting, you need to have a diagnosis. It needs to be in this particular range for care to be covered. But what about you, Damian, when it comes to informed consent? What's your normal process? And then I know we're going to kind of launch into where informed consent is not happening at the level that it should. But what is your process of informed consent with your clients?
So when I was working for the National Health Service, and just for all the listeners, so in England, in the National Health Service, it's free state healthcare. Okay. So when I was working for them, any assessment sessions or psychotherapy would be free. Okay. Now I've set up my own private practice now, so it's a little bit different, although some of the work I am provided is funded by kind of state organisations like schools anyway. But in the NHS, during an assessment session or in my private practice, I initially offer a free consultation. And during that, what we'll talk about is, what is psychotherapy? Okay. What type of things might you expect? What is the process like? But as well as talking about some of the potential benefits, I'll also talk about some of the difficulties which might come about. So, for example, actually, a therapeutic space is that kind of dedicated focused space where difficult emotions might arise during a session, because it is essentially a feeling space. It's not a social space. It's not a workspace. It's a different kind of space. And if difficult feelings are coming up and feelings that we might kind of sit with, or someone might come who's experienced trauma, and we talk about potentially the processing of trauma, is actually that can be quite distressing. So I think it's really important that a person is aware that although psychotherapy could be beneficial for their psychological health, is that there might be difficulties during the process for them as well. So we talk about the importance of kind of self-care after sessions, during sessions. So I think it's really important, okay, that they're aware of things which might become difficult during the process, because often we'll talk about how we're passionate about what we do and that it's effective, that it changes lives. But we also must be honest and open and give a person full information, and that there could be potential kind of detriments which could occur during the process. So we have a very open and frank conversation about that. So if somebody agrees to come into psychotherapy, they've got an awareness of what the process might be like. So that's important for us to be open and honest and work ethically.
Mm-hmm. Yes, absolutely. So I have a question for you, because our system is different than your system in the UK. When you are working with government funding, is a diagnosis required for care to be free?
It depends on which service you're in. So in England, the NHS, the National Health Service, is split up into different, what we call NHS trusts. So there are certain NHS trusts which are specific, say, for acute physical medical care, and some which are specific for mental health services. And often within an NHS trust, there could be different types of services, and some services may say, okay, our criteria is to access this service. For example, you must have a diagnosis of a personality disorder. Okay. Other services, so teams I've worked in, so for example, in adult care in some of the NHS trusts, you'll have what are called community mental health teams. For short, we call it CMHT. And for people to see me in a CMHT, they didn't need a specific diagnosis. They just could be someone who's significantly struggling with their mental health, right? And that type of approach, I think, is better, because I do remember working in other services where we'd have what are called referral meetings. And sometimes we'd receive a referral saying, would you offer, psychological therapy for this person? And some other people in the meetings would say things like, oh, I've noticed on the referral letter, this person has a diagnosis of bipolar disorder, personality disorder. Maybe they're too complex for our service. And I often used to kind of interject and make a point and say, well, let's look at the person as a whole. Let's just put the diagnosis to one side for a moment. And that's what the problem that you can see within certain services is. People think, right, they've got this attribution which they attach to a diagnosis. A person with borderline personality disorder, perhaps they're going to be difficult. They're going to be, these kind of terms like complex to treat, right? Yeah. And then what happens is we come away from looking at the person, right? Okay, why don't we look at the person? Oh, it's John. He's had this traumatic life event. He's currently living, in poverty. He's isolated. Is there something our service could offer? Could we help to meet his needs? Right. So sometimes you can get away from that. So some services you don't need a diagnosis to access services. Some you do, and I think for the reasons I've just touched upon, that can be problematic.
Mm-hmm. Absolutely.
Yeah, we found, both of us having had experience working at clinics that are in network with certain insurance companies, what you end up seeing is there is a lot of trying to make symptoms someone's experiencing fit into a particular label that then will get their care covered. And this is kind of a dirty little secret that happens where not only is the person lost, as you're talking about, their humanity is lost, their strengths, because it's so heavily fixated on that. It becomes an issue of how do we demonstrate they're making enough progress within this little diagnostic box we've stuck them in, but how do we also demonstrate to the insurance company they're still unwell enough to justify paying for care? And so it's this vicious cycle of focusing on deficit, of pathologizing, and all of these little, I'm trying not to be too derogatory in how I describe it, but to me, what feels like these little dishonest reframes that have to happen that, first of all, continue to kind of solidify perspectives that I think we were talking about this before we started recording. This idea that depression is something that you have, it's due to some neurological issue or chemical imbalance, and you're never going to be free from it. And what that does is it keeps the person trapped in this hopeless cycle of, I'm never going to get better. And it also
becomes their identity.
Yes. Mm-hmm. And we're treating them from that lens of, I'm seeing the dysfunction, not the person. But also we're telling people things that aren't necessarily justified in science. And they're believing it and taking that.
You know what I was thinking as you were just talking about, Elizabeth? It's almost like for some people, like in America, with the insurance companies, but probably also in England as well. It's almost like for some people, having this kind of diagnostic box, it's an administrative kind of thing. It's like, oh, well, it's just easier because I can tick a little box which says they have this. I was trained not to use diagnosis. My training, I'm sure you've come across it, we'll use something called Formulation. And just for the listeners who know why a Formulation, this is building up a deep understanding of why someone feels the way that they do, or why they present it the way that they do. So we kind of make links and say, well, this happened in your life. It led to you feeling like this. And then that happened. So it's kind of all making these things. So someone is sat in front of me and say, I never, ever cry. And I'm curious as to know why that is. Then maybe in the medical profession will say, well, it's a symptom of a disorder, right? But then I might say, I remember 5 sessions ago you saying to me when you were little that you got shouted at when you cried, and you felt really upset by that. And then it sounds like you've then started to shut away the tears because you open up. There's and anxiety that somebody might shout at you and something bad might happen, like it did when you were younger. So I think, but a formulation takes time, right? A formulation in a session, psychotherapy sessions, could take 5 or 6 sessions. I mean, during an assessment session, I could come up with it, I suppose, what we would call an initial formulation. Maybe when you start to generate some hypotheses, but it takes time. Whereas a diagnosis could be nice and quick, tick your box, and administratively, it's easier for people. But I think a wise supervisor during training once said to me, and this was on my specialist psychodynamic psychotherapy elective placement, she said to me, Damian, humans are complex. And she said, you can't box humans.
Yeah. Totally. And as you're talking, I'm looking at, the listeners won't be able to see this, but there's this sign behind Damian on this beautiful picture of the mountains. And it says, who looks outside dreams, who looks inside awakes. And I think that perfectly encapsulates everything that you're talking about, that when we look outside ourselves and we say, okay, I fit into this box, this criteria, we're stuck then. And I've seen it over and over and over again with clients where you get this label and that becomes a fixation. It becomes a crutch. It becomes the ultimate excuse of, well, nothing I do matters because that's not going to change how I feel. I don't have to focus on my nutrition. I don't have to focus on getting the right sleep or making decisions that are in alignment with my sense of meaning and purpose. And I don't have to go inward and do those things that you were talking about. Look back and see, where have I lobbed parts of myself off to fit into whatever environment I was raised in or whatever environment I currently find myself in. Everything is pretty much hopeless and outside of my control. All I have to do is take this medication and accept life as it is. Whereas if you look inward and you're curious of what's going on here, why am I feeling this way? And exploring, there can be so many amazing, incredible answers and shifts that can happen, but you have to release that box of the diagnosis.
Well, and the visual I got when you were talking about formulations was this kind of from more of the standpoint of how things are done here, especially if you work with insurance, you work at a clinic, is more of that kind of tunneling outward. I need to find the label versus the formulation is more, no, I want to go to the heart. I want to go to the root. I want to go to the genesis of this thing. What's keeping it alive? What's contributing to it? And an actual, and we've talked about this in the medical field here in the US, where there's more of this tendency to let's treat the symptoms versus let's get at the heart at what's contributing to this, whether we can then actually help with symptom remission or recovery, depending on what's happening. But how do you feel like operating from more of a formulation standpoint versus having to find this checkbox that they fit into and then operate from that and frame everything from that perspective? How does that help you be a better clinician?
I think I'm able to sit with my clients more so and develop a better, deeper, more special therapeutic relationship with them. Because as well, the type of therapy I use is more exploratory. We don't have an agenda at the start of session. And some services in England have a fixation on getting clients to complete what we call, like measures, questionnaire measures. So these are kind of usually measures, sponsored by companies like Pfizer, PHQ-9, and I don't know if you've come across that. It's supposed to be
we have those.
Depression scale. And I said to someone once, well, I don't need to give that to my clients because if I want to find information out, I'll have a conversation with them.
Yeah.
So whoa, novel, revolutionary. It's like, have a conversation, and one of the types of, one of the kind of sort of sub therapies of within the psychodynamic field talks about, therapy being sort of conversational, right? And I think there are certain aspects of sort of diagnosis or using measures or your tick boxes and all your administration things. And in England, they tend to be, will say, well, we need to measure things because the commissioners who pay for the services, they want to see that it's working and it's effective. So I kind of get that. And I know that we need to show kind of value and show that there's progress being made. But I think when I'm kind of sat with people in terms of developing that formulation, it feels a bit more natural, right? And it fits in with that, I suppose, conversational model. And I think, sometimes people will say, oh, well, you practice in this way because you were trained this way. And yes, okay, I was trained in this way, but I know what works. Okay. Mm-hmm. And yes, I reflect all the time and I get regular supervision. I learn from colleagues. I have good CPD. I don't know if you use that term in America, continuous professional development, further training and going on courses and continuing to learn. But I know what works with people and people are not sat there saying, oh, Damian, please give me a diagnosis, right? And I think I do remember, I think we touched upon this just before we started, and I was saying to you, there have been occasions where people have been given a diagnosis and they've said to me, oh, I'm not sure whether therapy would be helpful because I've got this brain disease and I'm stuck with it, aren't I? So can't really do much about it. So is there any point in therapy? And that's then where we'll have a curious kind of discussion. But I suppose that's one of the problems that I see with diagnosis. And you touched upon, both of you, a couple of the things, is that, and I was saying before, it almost becomes a person's identity. You see it on social media where people have, their disorder name as their handle, and they take photographs of their medication, and the whole identity becomes about having this disorder and this disease. And I think rather than celebrating the person and saying, well, this is John, this is Beth, and this is what they like to do, this is what they struggle with, this is what they'd like to see change and be different, it kind of gets stuck on that. And I think the label as well, particularly the personality disorder label, a lot of people with that label might have experienced, say, for example, childhood sexual abuse, which is horrific and has a big impact upon someone, or things like neglect as well. When a person gets to adulthood, they're understandably struggling to self-soothe and sit within relationships. And then suddenly, a doctor after half an hour says to someone, oh, well, your core of being, your personality is disordered. I mean, how insulting and shaming is that? So I think, but I mean, I suppose touching upon what we were talking about, at the start in terms of about consent, is we've talked about how we'll be open and honest about some of the potential advantages, disadvantages of psychological therapy. Are doctors, medics talking about, the potential pitfalls of receiving a diagnosis? Are they giving full information about side effects, withdrawal effects with the medications associated with these particular disorders? So is informed consent fully happening? And from what I've heard at an anecdotal evidence level, sometimes it's not happening.
Yes, I have to agree with that, especially, well, with all of it. But as you're talking about this new phenomenon where we are kind of diagnosis happy, or we want diagnoses. Elizabeth and I have both actually experienced clients who are actively asking for diagnoses. It's become such a fad to have a diagnosis, especially currently ADHD and autism. We're having a lot of people ask for autism diagnoses. While on one hand, it's great that awareness is rising and that people are trying to reduce stigma around it. On the other hand, there is that culture that's partially created, I believe, by the lack of informed consent, by the lack of therapists, doctors, whoever's doing the diagnosing, not telling people the limitations of the DSM as they hand out their diagnosis and letting them know, look, this diagnostic criteria, it might help you get resources, and that's why I'm giving it to you, or it might help you get your care covered, and that's why I'm giving it to you. However, we don't really know what it means. We don't really know if we've clumped these symptoms together in a way that makes sense. We don't really know if these specific symptoms are just variations of normal human behavior and experiences, or if they're actually an issue. We don't really know what's causing them, so it's not necessarily going to inform treatment the way that the diagnosis that you get. There's not really a chemical imbalance that we've been able to find, or a neurological difference that we've been able to scan for. So these medications that we are going to offer you might offer some relief, but could have long-term side effects even after you get off of them. There's so much when we just give somebody a diagnosis and we say, sounds like you're experiencing this, and then this is the treatment for it, then that's the tipping point of misinformation being spread all over the place. And I used, I think, an analogy the other day when talking to Elizabeth, where if I were to do the self breast examination thing that you're supposed to do to see if you have any lumps, right? And if I were to find a lump, and then if I were to go to a doctor or somebody and they didn't test, they just heard me say, I have a lump. And they said, okay, that means that you have breast cancer. And then they started giving me radiation. And then I took that information out into the public, and suddenly it became my identity. I have breast cancer. I have, I also have, 10 toes. So if you have 10 toes, and then you might have breast cancer too. And that's what we're seeing right now with diagnoses, is this really just huge inflation. And this informed consent process, I think, is a huge, huge part of the issue.
Yeah. Have either of you read the book called Cracked by Dr. James Davies?
I haven't.
No.
I'm going to write it down.
Okay, so it made me think when Andrea was mentioning something, and then about you've got this group of symptoms. So Dr. James Davies, he's at Hanson University in England. He's a psychotherapist now, kind of is a writer and lecturer. But in this book, he talks about, and he's kind of writes it in a narrative style, so it's readable. And he actually went over to America and interviewed some of the people who put together DSM-3. So I think there's, is it Bob Spitzer, maybe, I think, DSM-3 chair. Can't remember if I've got that name exactly correct. But anyway, he interviewed several people. He also interviewed an intern who was present during the compilation of the DSM-3. And basically, kind of what come out of it, there was no science behind it, no research behind it. It was basically a group of all male psychiatrists sat around the table day after day and basically saying, well, okay, so if someone experiences this, this, and this, what should we call it? Oh, we'll call it that. Oh, okay. And the intern actually likened it when they were deciding what to call the group of symptoms, what to call them, whatever disorder it was. She said it's like they were deciding what to have for dinner. Or should we have Chinese or Italian or this? Oh, we'll just have that. That was kind of how she likened it. And it was really insightful. It's a really good read. He's actually just published another book. I'm just taking it off my shelf there. I don't know if you can see that.
Sedated. How modern.
Sedated. How modern capitalism created our mental health crisis. So he kind of goes at a wider stance there and starts talking about actually how governments are set up and how everything is kind of set up is kind of geared towards sort of creating this kind of capitalist society where people are blamed and shamed for their problems, and they must get better quickly. That kind of societal approach fits in neatly with the kind of diagnosis, treatment, quickly get better. If you're not getting better, you're the problem, and you're not working, you're not creating and providing for society and being beneficial in our country. And So, but yeah, the original book I was talking about, Cracked, it's well worth a read. It also talks in detail about the research into antidepressant medication, and a lot of the research which he looked at with various kind of high profile kind of psychologists and psychiatrists have carried out, the medication is no more effective than placebo. And interestingly, very topical in England at the moment, because there's an investigatory program called Panorama, which is aired on BBC, which I'm sure some of the Americans are sort of familiar with the BBC as a broadcaster. And anything which is critical of pharmaceutical companies and that mainstream medical model doesn't often get too much airtime. But in this program, which was aired this week, it showed some correspondences from Pfizer where they told all staff to withhold some of the serious side effects which could come about from one of their antidepressant medications. It also talked about now it's becoming more common for people to experience emotional numbing, sexual dysfunction, and that what's happening is that the people prescribing these medications, and this fits in, with this theme and this point around, lack of informed consent. People are not being given information about the serious side effects. People are not being given information about withdrawal effects. Now, for years in England, even the Royal College of Psychiatrists were telling the public the withdrawal effects for antidepressants were minimal, not much of a problem. And lots of people campaigned, and they were actually forced into admitting that it was a problem. So this came up during the Panorama program as well. And a lot of people were unhappy with the program because anything which is aired, which is critical at all, of course, gets jumped on by certain people. But I think it's about raising awareness. And actually, often when I'm either teaching or taking part in debates, and I'll say, listen, we shouldn't get into conflict. Let's debate. All we're saying is, here's an in terms of using formulation rather than diagnosis, right? Or there's something in England which is receiving a lot of prominence at the moment called the power threat meaning framework, right? Because all we're saying is, here's a different way of understanding distress, right? We're not saying we've got all the answers. We're not saying we're absolutely right. All we're saying is, yes, there's diagnosis, but also there's other options of understanding the way that you feel. And besides medication, there are also alternative interventions, social and community interventions, kind of physical interventions, psychotherapy. There are various different, and all we're saying is let it be more of a balanced level playing field with the amount of information which is put out there. But I think with regards to the diagnosis and the medication, what we're seeing is informed consent isn't properly happening because they're not being given the full amount of information. And informed consent is the ethical cornerstone of good healthcare.
My concern is that part of the lack of appropriate informed consent is because, like you said, in the formulation of the DSM, it is not often talked about the realities of that. It is framed as though it is this book, absolutely built on empirical data, that's reliable, that it's the best we have. And so you have professionals who are themselves not appropriately, adequately, fully informed, who have this kind of these sacred things, like we don't question this. And so they're overly confident and they're not fully informed about all of the limitations or the scope of applicability. So then they're jumping to a particular serious diagnosis for their client, as we're talking about. They're not providing appropriate informed consent around that diagnosis, around treatment. That person might go to their doctor and they're going, well, I'm diagnosed with depression, right? And so doctor goes, all right, great. Yeah, you're suffering enough. Let's put you on a medication. And then there's all multiple tiers and levels of lack of informed consent that then, of course, as we talked about, keep people from getting well. And for me, that's one of the biggest benefits I found of freeing myself from what I see as this very dysfunctional system is I actually see people get well faster when I'm able to actually work and focus on the human being. Because like you brought up earlier in our conversation, these assessments, these procedures, it reminds me of the educational system. We want to try to prove how educated people are by training people. The better trained the kids are to memorize, regurgitate, and get a certain score on a test, which only benefits the people trying to validate what a great job they're doing, the bureaucracy. And in mental health, it's similar. These assessments don't actually really have a meaningful applicability so much to a client. Like you said, we can better
produce robots.
Yes. And it's made so we can go, hey, look what a great job we did, or to justify ourselves and continue to solidify our perception that this is the problem. And look, what I'm doing in this regimented way is working. When does that really translate to helping people? I haven't seen where there's a direct correlation of the amount of external assessment and all of this I'm doing to validate how wonderful I am or how much progress is happening, actually correlating with better care. I think it, in fact, takes away from that. I think as professionals, we have a responsibility to be speaking out. We have a responsibility to ruffle feathers, because if we don't, who else is going to do it?
Make good trouble.
Yeah. And like you said, us not being the opposite end of being so wed or committed to what we think is quote unquote the right way, but being open to this possibility of, we need curiosity. We need to be able to question these processes rather than doing more to get them entrenched, which often I think hurts more of our vulnerable populations and our patients than it does help.
Yeah, I think we need more flexibility, as you were saying, Elizabeth. And a thought that I had when you were talking about, often sometimes it's to do with maybe practitioners or professionals. It's to do with their own stuff about how maybe they want to practice. And it made me think about, well, how many of the professionals out there, whether it be counselors, psychotherapists, therapists, psychiatrists, social workers, whoever it is, do they understand themselves well enough? And I know, personally, for my own personal professional development, I've been going to psychotherapy weekly for 7 years. So I've got a good idea of what it's like on the other side of the room. And also I try to keep a good understanding of my own stuff and what's going on for me, which then I think helps me, not just myself personally, but also for the work that I do. And yeah, this kind of, you were saying there, you're being human with a person, you've seen that have benefit for the people that you work with. And I see that too. And it's often about, a wise tutor during training, this is another one, said to me, everything's relational. And actually, the relationships I've had with the people I've worked with have been genuine and warm. And, and that has helped to bring about change and help people to recovery.
Yeah. And it's such a complicated question, right? Of how do we direct the mental health field? I saw a talk by Dr. James McPartland where he talked about, where do we go? He was specifically talking about autism. He said, where do we go in the next 10 years with research about autism? And he brought up a point that I really agree with, and I think ties into what we're talking about, is we need to stop focusing on figuring out what autism is and how to treat autism. And instead, we need to focus on each individual symptom and how it interacts with each individual person and how to treat that. And I think that applies to the entire DSM or the ICD or whichever version you're working with. The more that we try to focus on these categories, the more we're missing the mark. We're missing the human. We're missing out on all of the little puzzle pieces that make it up. And I've never seen it be effective with these assessments that you're talking about and that Elizabeth is talking about as well. They tie back to the DSM. They're not about the human. If somebody comes in and they say, I've been diagnosed with depression, we still have to ask, what does that mean for you? What does that look like for you? We don't know what that means, right? And then they tell us. And then we give them these assessments and it ties them back to the criteria in the DSM over and over again, as opposed to, if we just look at what is your main, what is bothering you? What's really getting it to you in your relationships, in your life? And then we focus on that. that's where it really matters. And even with medications, if we're looking at what's a medication that can treat this entire diagnosis, we miss the mark and we create other issues, like you're saying with the Pfizer situation that's happening currently, with talking about, do these antidepressants do what we say that they're doing, and are these side effects okay or not to be giving to people?
Yeah, just touching upon a few things you said there, Andrea. One of the sort of people say an advantage of a diagnosis, this kind of argument sometimes put forward in England, is they say it's useful shorthand. Okay, so they'll say, if maybe a child's going to a school, they can say, oh, they have ADHD, or maybe an adult's going to a workplace and so, is there anything we need to be aware of? Or will they have bipolar disorder? And people think shorthand, great, but like you were saying there, if you say someone's got depression, you'll say, well, and what does that mean for you, right? Okay, because if you go to you go to an internet search engine and type in ADHD, bipolar disorder, whatever it is, you'll get a generic description. You're not going to get a personalized, individualized understanding of the person, right? So the shorthand argument doesn't kind of really fit, because you're also going to have to say, okay, well, what is it in particular about Alan, who's going into a new school? What is in particular about him? And then someone might have to say, well, actually, he tends to find it hard working in big group settings and tends to find it easy working in smaller group settings. Okay. So then the personalization starts to come up. So if you're going to go into the personalization anyway, you don't really need the diagnostic label.
Like you said, the shorthand, who is all of it meant to benefit? Right? Like you said, obviously, using that shorthand with a school to try to get your child access to extra support. Sure, ultimately, you're trying to benefit the person, but the fact that we've set up our systems in such a way that we must label people, sometimes I think very much inaccurately, is a real disservice. But then too, it has no benefit to the clients. And in fact, as Andrea brought up, we have both experienced individually clients who somewhere they have lost themselves in the process of trying to heal. And they are not only asking for a diagnosis, but a specific serious diagnosis. And you can sit and you go, I've worked with you for 2 years. I've worked with you for 3 years. I'm telling you, you don't fit the criteria, but let's even talk about why is it you feel that you need this diagnosis? Again, I think that's where there's not enough of us speaking out, I think, as clinicians who hopefully we should have all of the information to be able to share. We're not counteracting some of these toxic narratives and even misinformation that people are receiving, but then it's forming a social dialogue about what it is to have ADHD, what it is to have a mental health disorder generally, what it is to have autism, to where you have people self-diagnosing and claiming and self-limiting. But I think you were going to say something as I kept talking.
Oh, yeah. It just made me think, because we were being critical of certain professionals who, the diagnosticians giving out the diagnosis. And I think in my experience, there's probably less people seeking a diagnosis in England, some people. But actually, for the people who are seeking a diagnosis, you were touching upon there about why is that? And I think sometimes it's a psychological defense. Okay. So actually exploring and touching upon the stuff that has caused their distress and difficulties might potentially feel too overwhelming. So it's easier to attribute their difficulties to, well, I did that because I've got OCD, or I did that because I've got bipolar disorder. So then actually it becomes a shield, and they don't have to go murking at the difficult stuff.
I 100% agree with that. And also, I think it can be overwhelming in the other way as well. Like you were talking about earlier with this sedated book James Davies wrote. And I've seen it a lot as well, just where our society is not set up for us to function optimally as humans, to feel okay as humans. We're set up to be as productive as possible, to sit still all the time, to be alert all the time. Yes, to not make mistakes, to only be emotional very appropriately, to always say all the right things. And we have a microscope on us at all times. We are getting overwhelmed, where I don't know anybody who doesn't have some kind of sensory processing issue at this point, because we're being constantly inundated with some sensory experiences while being completely deprived of other sensory experiences. We're not okay. So some of it is absolutely exploring internally, and others is we need big social change. Even as we're talking about informed consent, I'm thinking, how do clinicians even do that? Myself, when I've worked at clinics that require a diagnosis because they work with insurance and they really push even specifically some certain diagnoses, you can't really sit there and tell your clients all the informed consent about diagnoses and risk them leaving the clinic and not working with you, because then you as a clinician are going to lose your job, and that's your livelihood. Or we have the medical schools that are funded by these pharmaceutical companies, and the Pfizer one is the one that's happening in the UK right now. Recently, a couple of years ago, we had Shire Pharmaceuticals. There was a big lawsuit because they were spreading lies about Adderall and ADHD medications. And these are the companies that are funding medical school, and they're funding that. We call them continued education credits here. You called it something else there, continued professional development. But they're funding the doctors, and they're going in and and the doctors are overwhelmed and the therapists are overwhelmed, and we're all just trying to do our job. So there's even systemic stuff that's hampering our ability to do thorough, honest, informed consent as clinicians.
I was just interested to say, what is you two? What is your experience of causing good trouble, being critical, speaking up? Because what happens in England sometimes is we'll get called. We'll get labelled. It's done to try to slow us and silence. Oh, you're anti-psychiatry, right? Or you're a pill shamer if you make a critical comment about medication. And I'll say, well, we should be able to debate. It's not about who's right or wrong. It's about having a conversation. I'm just wondering, do you end up getting a lot of conflict and, from people?
So we have a couple of recent examples. I'll say, me personally, part of my personal decision not to be a part of the dysfunction was to remove myself from the way the general clinical settings operate. And so to start my own private practice. And then, of course, working more on a one-on-one case with my clients. I'm not necessarily coming face to face with other clinicians unless I'm seeking consultation, like with Andrea or with others, to help my clients. But probably the biggest way we're collectively trying to speak up against certain things in the field that we find are destructive or aren't helpful, including even the teen treatment industry, which is something we've talked about, we're going to continue to talk about, is on the podcast, but also trying to do outreach kind of socially. Not that it's necessarily the best way to do it, but we experienced, especially Andrea, major horrible kickback in just trying to provide education in comments or videos we're seeing people post that aren't going challenged. For example, there's a lot of people talking about, well, I have a strong commitment to justice, and I was told by my therapist, or I watched a video that said only people with autism have a strong sense and commitment to justice, and therefore people who are neurotypical, and there's these neurotypicals, these negative labels, they don't have a commitment to justice, only us. And so there's totally misinformation. But when we were trying to go in and correct and provide alternate perspective, Andrea, literally share what you experienced just from trying to provide correct information to misinformation.
It was a bit of a mob online. There was a lot of people, and they were finding me on all of my different social media outlets and trying to yell at me and comment my things. They got the phone number for, in Utah, it's called Doppel, the licensure department, and they were spreading that around, saying that they should call in and try to get my license revoked, that they reported me to the APA, which I'm a clinical mental health counselor. I'm not a psychiatrist. So I don't belong to the APA anyway, but they did that. They were trying to find personal information about me to come after me.
They doxed the wrong person.
They doxed, two of the wrong people with my same name. It was a lot, and this stuff, it happened. Horrendous. And even other clinicians as well in workplaces that I've had bosses, just yell at me for trying to provide proper care to clients or informed consent to clients and make all kinds of accusations and threats. And it's held very deeply and closely. And I know that from our previous conversations, you've had people coming after you as well. You said, especially on Twitter.
Yeah, I mean, I started the conversation off quite lightly there by saying sometimes we'll get slurs like antipsychiatry, but unfortunately, your story, Andrea, kind of resonated with me. It's happened to me and a number of other people. We're not coming onto forums and social media platforms and discussions and podcasts. We're not kind of saying, look, I have all the answers. I'm completely correct. What often people do, and everyone will do this individually, is they will speak from experience. Okay. And I'll speak, with my training, my experience of sitting day to day with people. And unfortunately, we've had people making complaints to workplaces, making complaints to regulatory bodies. And, obviously, because there's nothing to those complaints, they get thrown out. But, the process can be stressful and people manipulate these systems and processes because there are certain, I don't know if it's like this in America as well. It seems to be like this everywhere at the moment. Is you go to a workplace regulatory body, literally they have to investigate everything. And I joked to someone the other day, it's like if I put on Twitter, I like cake, and someone says, "Well, that tweet distressed me." Suddenly they're making a complaint.
You're in trouble.
Like, oh yeah, we investigate everything. Please come on in. And it's like pandering to people and who are out to abuse the likes of you and I. And these systems are set up almost to help aid their harassment. So I've had to get the police involved with some people.
Wow.
I'm not the only one. The person who fronts up the power threat meaning framework in England, the clinical psychologist, her and some of her colleagues, have had the most horrendous abuse. And then you start to think about, why is this happening? And I think you've got pharmaceutical companies, you've got professionals who are professionally invested in this medical model kind of system. I think people are feeling threatened. Actually, we're coming out and saying, well, look, there are alternatives. There are different ways besides diagnosis to understanding distress. And I think, unfortunately, some of them feel threatened and then they start to lash out, which is obviously inappropriate, and then kind of just makes their argument or viewpoint fall down, really, because it's like, well, hey, you're being abusive. Is that your style of practice?
Yeah. And it's really, I think, challenges a sense of identity, unfortunately, in this field. I think in a lot of fields, but especially in the medical field, we identify so much with what it is that we do. Doctors are doctors and it's who they are. So if we're challenging the way that they've gone about practice for X amount of years and all of the education and all of the student debt and all of that they got into to be this person and treat clients in this way, that's their identity. And then the way that diagnoses have shifted into, like we were talking about earlier, the sense of I am my diagnosis, I am ADHD queen or whatever is their social media handle, and that's all they talk about. Then if we are challenging the diagnostic system, then we're also challenging their identity. So it shows, I think, just like you're saying, it shows the glaring issue in the diagnostic system that we are becoming this identity and grabbing onto it so strongly, and it's really limiting our ability to be human, our ability to think outside the box, our ability to think critically, to listen to other opinions, to explore all of that.
Our ability to feel, our ability to awake, like your poster says, as we were talking about that earlier, it's painful and it's vulnerable to, as professionals, step back and allow ourselves to be unsure and be clear about where the field has limitations and is not clear, and that we're operating often full steam ahead, but it's not often off of information that necessarily validates that. It takes courage to take our shields and our security blankets off and have these conversations. And then again, as you were saying, that parallel with with clients as well, trying to empower people so that they don't feel they need to cling to that security blanket or that shield in order to
be themselves.
And that is not themselves. It's an external label, and they are so much more than the sum of their quote unquote symptoms.
I often give certain examples during these debates. I'll say, okay, so there was a mental health institution originated many decades ago in England called Bedlam. Unfortunately, it's kind of tagged onto a word in England. If something's a bit chaotic and just so, someone say, "Oh, it's Bedlam," so it's kind of used in the English language as well. But I mean, this is, I'm not sure how many decades ago, but the intervention of choice at Bedlam for people with mental health problems was purging. Now, imagine if no one had challenged that. Maybe at the time people were saying, well, I'm not sure whether purging is very effective at helping people with their psychological health problems. Oh, no, you this, you that, and maybe they get attacked. But obviously that changed. And then probably maybe talking about 2, 3, 4 decades ago, someone had a panic attack in England. They could end up in what was known at the time as a mental health asylum, right? Locked up maybe for years. And then let's not forget that in the 70s, on the DSM, what was on the DSM? Homosexuality was classed as a psychiatric disorder. And imagine if nobody had challenged that.
Yes, absolutely. And so many atrocities, and missteps. There were torture, just legitimate torture as mental health treatments. And there even still are. I mean, in the US, ECT, yes. And lobotomies aren't illegal in the US yet, and in most states. So it hasn't happened really since the 70s, but it still is on the table. And the 70s just wasn't that long ago. So there have been missteps. And I love that parallel of, if nobody had said anything, if nobody had challenged it, then where would we be now? And even the whole, demonic possession and all of that whole stage of the mental health industry, we have a responsibility, we have a duty. So I appreciate you being all the way out there in the UK away from us, and you're doing the same thing. You're spreading the same message. And for me, that's comforting. And books like you bring up by James Davies, and I also love Dr. Alan Francis. I bring him up all the time. He was on the chair of the DSM-4 and 4TR, has written a lot of great books. But what we're talking about here, it's not conspiracy theories, right? This is hard data. This is hard facts. And
or lack thereof.
And or
acknowledging lack thereof.
This is what I see every day in work.
Yes.
This is what I see every day in work. I sit with people. We understand why they're struggling. We use a formulation. I don't just recommend psychotherapy. Sometimes I could recommend psychotherapy when I was working for the NHS. Now I'm private practice. I work very ethically, and I'll sometimes say to people, well, this is here if you'd like to access it, because it's paid. So the dynamic changes a little bit. But I'll often also say to people, look, maybe go and try NHS services first, because you can access therapy free there. I know what works, because sometimes you can get frustrated and say, well, why can people not see things? I've got a number of colleagues, and there's obviously yourselves in America, who are working in compassionate ways, who value that human relationship, not like in and out the door in 10 minutes. Because, I mean, I've worked with some excellent psychiatrists in England, so it's nonsense to kind of say it's this anti-psychiatry thing. But unfortunately, sometimes when I was working in the NHS, you'd hear from clients who'll say, I had me a psychiatry review the other day, first one for 4 months. And they'll say, oh, it lasted 10 minutes. And I got asked her, how you doing? Yeah, not too bad. Okay, yeah, see you in 3 months. Or if someone says, oh, I'm struggling a bit at the moment. Okay, well, we'll up your dose of your medication. I don't know if you see this as a problem in America. It's this trend in polypharmacy approaches, right? So, you'd meet someone and it'd be like, they'd be on 4 different medications.
Oh, yeah. I've met people on 20 plus different medications.
And it'd be like things like, you'd start having a conversation. When they put me on this antidepressant, it didn't work, so the dose, it didn't work. So then they put me on this one, it didn't work, the dose, it didn't work. Then they put me on this one, the dose, it still didn't work. Now I'm on this one. Is it helpful? Not really. But I think the problem is with certain mental health problems of professionals, and this is down to poor training, I would say, is their go-to is medication. So maybe a client phones up, what we call like the duty line. So client phones up in between sessions, maybe they've seen the nurse and me and whatever, and they'll say, "Oh, all right, I've got a new symptom. I'm getting intrusive thoughts," and their instant go-to is, "Okay, well, we'll prescribe you this," and they're already taking maybe 3, so they're on this 4th. And my instant thought is, let's understand this psychologically. Let's think about what social psychological kind of strategies that I could recommend, which might help understand that better, reduce that, help calm that. So, this, I'm sure you've heard this saying before, is this a pill for every ill?
Well, and I've had this with clients who, as you're talking about people on multiple medications and serious medications with serious side effects.
Yeah.
Where they will come in, and when they're spending maybe only 10 minutes or so with a psychiatrist or a prescriber, that's not even enough time to even go over the negative side effects, let alone to get a meaningful assessment of how someone's doing. But I had someone just the other day who we sat down and he went, "I'd really just like to know what of the symptoms I'm experiencing are actually from me versus coming from my medications." Because when you brought up somebody going, "I have a new symptom," part of, I think, with me and empowering my clients is, of course, I sit back and I go, well, you deserve to talk to your provider about that. You deserve to sit down and ask them questions. If they're not volunteering the information to say, I want to know all of the side effects, what do I need to look out for? Not just hand me a pamphlet. I want to talk about these, because when I have somebody who has some serious challenges, but then they're on 4 different medications, and we can't differentiate what of their symptoms are really coming from physiological, interpersonal, lifestyle choices, or medications. That's concerning to me, because we could pathologize all day or try to talk through their issue. But if it's lifestyle related, but we're not talking about lifestyle choices, if it's relationship related, but we're not talking about it, if it's coming from a medication that they're taking, but they're not exploring that, we could talk about it all day, and then they're personalizing the experience of a symptom, sometimes thinking, well, what's wrong with me? And it could be, this is a side effect. I had this with a clinician I received therapy from while I was in my master's program. He was wonderful. He was a psychologist, but he never talked to me about physiologically what was going on, or if I was working with my doctor. I had an undiagnosed autoimmune disease at that point. So it was lovely what I did with him, the work I did, but I could have improved so much more and received other beneficial support if even he had helped me recognize, are you talking with your doctor? Like, there might be something going on. I had a thyroid issue, but we could talk all day. We were not going to solve the fact that there was some dysfunction. But then even there, right, with a medical doctor, you can treat that with a medication. There's lifestyle things that also help treat autoimmune issues, but you go to the doctor, they give you a pill. They're not saying, hey, let's talk about the dietary things that might be triggering or making worse your autoimmune. Again, levels and levels of lack of informed consent.
And the thing is, sometimes we'll get attacked and they'll say things like, oh, you're saying a bit of exercise and a bit of mindfulness will suddenly change my life. And we're not saying that, but like you were talking, Alice, it sounds like you kind of say more holistic care would be more effective, because I always say to people, okay, psychotherapy is one element of what you have in your life at the moment. Now, there are other factors, and I'm not suddenly saying if you change, so we're talking diet, sleep, exercise, relationships, whether they have quiet time, spaces for themselves, rest, are they engaging in things that they enjoy? I'm not suddenly saying, okay, you change a couple of those factors and you suddenly go, oh, I feel wonderful. But it might be that maybe if you change one of the factors, it helps 5%, right? And that's something, right? It might be if you change another factor, that might help 5%.
That's part of that informed consent, is also making sure we're not treating therapy, as you're saying, as the end all be all. And more to shift that on to take a med and that's the end all be all, or do self-care better, or get more sleep and that's the end all. I think part of the informed consent process is understanding the potential value, the potential risks, and the limitation, and helping people, I feel like empowering people to be empowered in those other areas of their life. and then advocating as well for with other professionals they might work with in other areas of their life, and requiring appropriate informed consent as well, which can be difficult.
Yeah. Oh, I know that this is a conversation that the three of us could just have all day long.
All day,
all night. We could get together and have a week-long just conversation about all of this.
We'll come up with a course for people in England and in America.
You should. Great.
I'll jet over. It gives me a chance to come back to America.
Perfect. Yes. Next time you're in Utah. We have so appreciated having you on our show and having this conversation. And I hope that those who listen feel, hopefully it would make sense to feel some frustration or some disappointment. I know for me, in my own journey of figuring out what is beyond diagnoses, there was some anger about, well, why did nobody tell me this before? Why did nobody tell me that there could be something deeper, right?
Yeah.
I hope in all of those emotions that there is also some feeling of empowerment and of hope that there are plenty of professionals out there looking at how can we provide something that is beyond this box. And for those in your area, in the Liverpool area, Dr. Damian, how can they get a hold of you if they want to seek services from you or training or supervision?
So like I was saying at the beginning, I've just recently set up my own private practice, which is called Wilde Psychology. So Wilde with an E, WILDA. I have a website which somebody else created for me because that is not my forte. So the website address is www.wildpsychology.co.uk. So the website, it doesn't just list services I provide. It also has some free resources on there. So if people want to drop by the website and they're not actually necessarily interested in contacting me about services that I provide, is that there are articles on there that people can read. There's other podcasts that I've done. There are links to good booklets for people who've experienced trauma and other kind of psychological health problems. So I think ethically it's important for me that I put those kind of resources on there, which people can tap into if they think, well, I don't want to access any particular service, Damian offers, but I'll browse the website, do a bit of reading, maybe download some of the booklets, things like that. So that is my website, and people can feel free to browse. In terms of psychotherapy, as well as seeing people face to face, I do offer psychotherapy via Zoom. So I do sometimes see people from different areas in England and even different countries.
We will definitely have to stay in touch, maybe have you back again to even expand on some of the things we've started to talk about today.
I'd just like to thank both of you two, Andrea and Elizabeth. And it's kind of heartwarming to see over there in America, there are people like you that are not only kind of speaking up about some of the important issues and raising awareness, but you're also on the ground providing sort of good quality ethical care. So that's kind of heartwarming to see. I think the podcast is one really good way of kind of getting voices out there and letting people think and be curious and to ask questions. And I think that's really good. I also, in terms of debate as well, sometimes I'll have debate on the social media platform Twitter. So I'm on there as at Dr. DJ Wilde. I'm not a music DJ. It's just my middle name. My middle name is Joseph.
That's great. Yeah. That's perfect. Yeah. And I look forward to continuing to see your posts on Twitter and LinkedIn. And I really hope also for any clinicians listening to, really consider expanding that informed consent as kind of our main topic today. Yeah. That is our ethical duty. I strongly believe that it is our ethical duty. I've had other clinicians question me and say, well, if we tell everybody everything, then they might choose to not get services. Yes, that is the definition of consent, telling everybody everything, and then they get to say yes or no. If we are deciding for them that they are incapable or incompetent or too mentally ill in some way to be able to exercise their free will to consent to things, then that is a slippery slope. So for clinicians out there who are listening, I would love to hear your thoughts on informed consent or what this looks like in your process, and strongly encourage you to really look at the informed consent process and see how you can improve it.
Yeah, I'd sort of concur with all of that. I mean, if you look at sort of medical healthcare, if you were going for an operation, you would be very clearly told, look, these are possible benefits if you're having this operation. These are the possible side effects, right? And it would be clearly communicated in maybe written form, verbally. And so people can sometimes think, well, psychological health, is it a bit more ambiguous? Is it less clear cut than, say, talking about an operation? Maybe it is a little more difficult to outline some of that, but it is absolutely essential, because when people come to see us, they are trusting us with part of their lives, their feelings, which they might have kept hidden for a number of years. So this is really serious and important work. So we have to be open and honest, and remember that informed consent is the cornerstone of ethical healthcare.
Thank you so much, Dr. Damian. Definitely, everyone, look him up if you can, if you're interested to learn more. Thank you for everyone who has been listening online. If you have questions for Dr. Damian, definitely feel free to send those to us. We can send them on to him or reach out to him directly. And if there's any topics you would like us to explore further from what we talked about today or from past podcasts, let us know and we can make sure we touch on those. Keep an ear out and an eye out for our upcoming podcast where we might explore some of these topics and more. But everybody, take care of yourselves. And Dr. Damian, you take care of yourself as well.
See you later. You have a great afternoon.
Ciao.